Hello everyone and welcome back. I'm Joe Chappelle and you're listening to episode 17 of the OBGYN podcast. This is the Journal Club episode for May 2017, and as always, meaning the second time, I am joined by Dr. Jerry Ballas from the Baylor College of Medicine. Hey Jerry, welcome back.
Hey Joe, thanks for having me back.
I think this is going to be a good one. So this article was chosen by Dr. Ballas, and it is from the Gray Journal.
I believe it was April 2017.
Right, and it is Planned Home Births, the Need for Additional Contraindications. The first author is Amos Grunbaum, and the final author is Frank Chervenak. As a little disclaimer up here at the top, Frank and I are both on the editorial board for the Journal of Perinatal Medicine. I don't know him all that well, to be honest, and we have not discussed this paper, but I do want to give that little disclosure up front.
And also for me, the second author is Lawrence B. McCullough, recently retired ethicist at Texas Children's Hospital and Pavilion for Women, which is Baylor College of Medicine's teaching hospital. So I did have an opportunity to work with Dr. McCullough on several different consults and events, but have not discussed this paper specifically with him. And part of the reason I actually chose the paper, knowing Dr. McCullough and Dr. Chervenak and their works in the past, I knew it was going to be a fascinating read of a mix between ethics and statistics, which I think they do a very, very good job doing.
Yeah, I think that's something that we're going to have to talk about in this paper, because the stats, any of these kind of papers, and we'll get into what this kind of paper means in a second, a lot of it hinges on how well the stats are done, and so it's an interesting discussion there. I mean, overall, this paper is essentially about what makes a safe home birth, if anything does. My only caveat after reading this paper, and I'm sure that many of you will probably agree, that there does seem to he definitely wears their bias on their sleeve here, and you can kind of feel that they don't really think any home birth is appropriate. And so there is that factor, and I do want to discuss that when we get into the discussion, because I feel like there's some trade-offs, and they do mention them, that I think make interesting discussion that we can have with ourselves and our home birth colleagues. But why don't we get started with the paper? Jerry, why don't you kind of walk us through the introduction, if you would?
So the introduction I thought was pretty straightforward in spelling out the statistics for the home births that occur in the United States. 2014, which is the last year of the data they were collecting, there were 37,551 home births, which is the highest absolute number of all industrial countries, and that's the reason they, I think, say absolute numbers, because proportionally, there are other countries that definitely have higher percentages of home births. We are seeing an increase in planned home births amongst several different populations, which I think prompted ACOG to come out with their committee opinion in 2016, and then updating again this past April in 2017 in order to help direct safer home births. And they do go through the risks that have been published in the past for home births, in terms of increased risk of neonatal seizures, neurologic dysfunction, increased risk of 5-minute APGARs of 0, less than 7, and less than 4, increased risk of neonatal death and a breech presenting fetuses. So they do kind of set the tone for, I guess, a bit of a negative bend on home births. And they do outline the 3 contraindications that ACOG has stated in their committee opinion in terms of recommending women not try home birth, which include, where are they? Where are you?
I have malpresentation, multiple gestation, and trial of labor after cesarean.
Correct.
Yeah.
Correct.
So as is my wont, I went back and I looked at all their references, because I think that there's something, especially in the first reference, that I think is going to come back into play for us later, and that is from the Chang 2013 article, which if I scroll down here, I can tell you what the name of it was so people at home can follow along. That was Selected Perinatal Outcomes Associated with Planned Home Births in the United States, and that was from the Gray Journal in 2013. And what they found was that home births were associated with, APGARs less than 5, which they say in the paper, but you gotta look at the percentages, right? So in hospital deliveries, 0.24% of deliveries had an APGAR less than 5, and 0.37% had an APGAR less than 5 when delivered at home. So yes, there's an increase, but it's from 0.24% to 0.37%. So how many actual babies are we talking about? Because obviously we don't deal in percentage of a baby, we deal in whole babies. And so the whole baby increase really wasn't that high. And even in the neonatal seizure, it went from 0.02% to 0.06%, which is a threefold increase, if you want to say it like that, but it's really only a 0.04% absolute increase. And just the last one that they talk about in the paper is they looked at operative delivery, and not surprisingly, in a hospital it was 6.2%, whereas at home it was 0.1%. And I think this is a lot of where the argument for home birth, or not even the argument, but the women why they want a home birth, right? Is they want that lack of intervention. They don't want to go to the hospital and be, at the whim of the doctor. And so you can look at this and say, sure, there's an increased risk of neonatal seizure and decreased APGARs, but look what a reduction there was in operative deliveries. So I want to point out that there's multiple ways of looking at this data. From a medical point of view, I think I'm always going to look at it from the neonatal safety point of view, but there's another way of looking at it.
Yeah, and that calls into play these population-based studies, and we'll talk a little bit about that in materials and methods. When you start getting to large enough ends, these small differences start becoming significant. If you have a large enough population, then you're going to be able to detect very small differences. And so what is the clinical relevance of those small differences?
Right. Well, as I say, a million here and a million there, and eventually you start talking, real numbers. They do add up, though. Anyway, I think they did a really nice job in the introduction, kind of laying the groundwork. The one thing in the introduction that I thought was interesting, and that is the aim of their study, right? So they say their aim of their study is to look at these 3 different risk factors that are not currently listed as, contraindications to home birth that they want to look at. And those were, nulliparity, gestational age greater than 41 weeks, and women age greater than 35. And one of the things I wish they had done here is tell us why those 3 things.
Well, I can tell you probably the nulliparity would be the risk of labor dystocias in general in nulliparous women is higher. Gestational age over 41 is almost a proxy for both estimated fetal weight, so larger babies, but also placental dysfunction. Women over 41, when we approach 42 weeks, is where you start seeing a rise in the background incidence of neonatal demise and labor issues. Women over 35, I would think they would have gone over 40, but I think 35 is your advanced maternal age cutoff for various complications. So that would be my guess as to why 35 was used.
Yeah, so again, if you go back through the references, this same group, or at least Chervenak, I think there's somebody else from the same group. Yeah, Grunbaum. Actually, basically the whole people. Never mind. They have published another paper that was 2014 in AJOG, and they found some of these risk factors, which were these risk factors, except for the age, with home births. And so now they're taking it a step further and investigating them. But I shouldn't have had to go through the references to find out why they chose these. Right? They should have had a paragraph that said, whatever, even quoting their own paper, fine. So know why that these 3 particular risk factors were pulled out of all the other risk factors you could think of.
Right. Sacrificing completeness for brevity.
Right. So again, that's more of a critique on the literature as opposed to the research. But it was something that I noticed. Again, when someone's reading this and... again, most of us who skim these articles don't get, we don't critically read all of articles that we read, and so they might miss that. So anyway, that was that. So you mentioned the materials and methods are going to be interesting in this paper, so why don't we dive right into those? Mm-hmm. This is definitely a population-based study, and that has a lot of differences than the study we did last time, or even a lot of the clinical trials that we read on a regular basis. So what do you think the big... I don't want to say pitfalls, but the big concerns or questions you have to ask yourself when you're looking at a population-based study versus, say, a randomized control trial?
Well, with population-based studies, you have little control over the quality of the data that you're linking from the absolute endpoint, which in this case were the birth certificate or period-linked birth death files from the CDC, leading all the way up to that moment. So things like hospital records, detailed notes, patient factors, all of that's been predetermined for you. You have to work backwards to try to make those associations. And so in the end, you are basically going to be making associations based on these absolute endpoints. And that's where, the old adage of association doesn't necessarily mean causation is always going to be a limitation of these retrospective population-based studies.
Yeah, I gave a grand rounds a few years ago on big data in medical research, and this is a good example of that. When you deal with big data, as you said, I think very well, you accept the fact that your data is going to be messy, but in return, you get a lot of data.
Correct. You try to overcome that. You're trying to smooth out the curve with lots and lots of data points.
Right. And the other thing that I think you said there is very, very, very important is that these big data, in which population-based studies are a form of big data research, never, or I shouldn't say never because nothing's never, but pretty much never can prove causation, right? Mm-hmm. You said it, but they can only prove association, and that is worth saying 2 or 3 times because you will see some papers where they don't say it right. And it's important to know that they actually can't prove causation. And this is a starting point. You say, okay, so now that we know these things, now let's design a study to see if these are causative or actually just associated. And then the statistical analysis, I don't know how much you want to get into it.
I mean, they basically went into hold on one second. Mm-hmm. So, first off, the definitions: neonatal deaths, pretty standard that we use between days 0 to 27 of life. And then they decided to use 3 groups, which I thought actually was kind of an interesting part of the paper. They had the hospital-attended births by certified nurse-midwives, hospital-attended births by physicians, and then the planned home births. And I think that actually gives a nice 3-tiered risk stratification, if you will. We always talk about, most births in general should be attended by midwives because the vast majority are what we call low-risk births, low-risk pregnancies. The hospital-attended ones by physicians can be almost a mixed bag. Yeah, you're going to have your low risk, but they tend to be the ones that also don't fall under midwife care, have an extra risk factor, or something intrapartum has transferred them to MD care. So you're going to see a mixed bag of results. Whereas the attended home births is where you really start to see a lot more variation in provider skill, provider training, and a lot of different variations in how care is executed for the birth. And so I did like the stratification in that regard.
One thing I think is interesting to look in their stats here is they give us a standardized mortality ratio, which is something that is used in again a lot of these population-based, especially you're talking about any kind of death, right. And we don't see it that much in obstetrics and gynecology. So I do think it's worth mentioning for a minute how they set that up. And essentially, they choose one group to be the reference, and that reference is 1. And then everything gets compared to that. So it's just a different way it's almost like a relative risk. It's just a different way of looking at it.
Yep, and that group they were using were the hospital births attended by midwives.
Right. To go back for a second, I did want to just briefly touch on their inclusion and exclusion criteria, because they're actually pretty simple. Just to point out, they did choose term, singleton, normal weight babies who were non-anomalous, so had no congenital birth defects. And then their exclusion, and again, a little of this comes down to how the data is represented to them, but they excluded anyone who didn't give birth in their home or at the hospital. So I hope it wasn't that many, but people who deliver in the car or the cab or whatever it may be, the train, if it will. And so they did do that. The one thing they mentioned, and this is in the discussion, but I'll bring it up now, is that they also looked at whether the home birth was intended or unintended, because we've all had patients. In fact, Jerry and I can probably remember a specific one. We won't talk about it on this podcast, of a lady who delivered at home. But
live on 911.
Exactly. But whether that was intended or unintended, because some women do deliver unintended at home. But what they couldn't tell was if the woman delivered in the hospital, whether that was intended or unintended. So basically, did women who want to have a home birth get transferred to the hospital and then deliver there? And they couldn't capture those women. So there's something to keep in mind when they look at the data. All right, so let's move on to our results. And the first thing is, we don't often see numbers this big in our study, and so right. I'm going to read this number out because I'm just so impressed by it. They included 12,953,671 singleton, non-anomalous term deliveries with infants who weighed more than 2,500 grams. That's an impressive number.
Any researcher's heart flutter.
Very, very impressed. So about 90%, 91% delivered in hospitals by physicians, about 8.3% by certified nurse-midwives, and then but 0.7% were planned or intended home births, which it's actually a pretty impressive number.
No, absolutely a robust absolute number of home deliveries.
And then looking at the neonatal deaths, let's see, they had 93% of them were from hospital deliveries by physicians, 5.2% by certified nurse midwives, and then 1.8% were from home births. Now you can see right there that even though the home births only represented 0.7% of all deliveries, they had 1.8% of all neonatal or perinatal deaths. Mm-hmm. So you can already see right there that there's going to be an increased number. So let's move on to some of the results. I broke down some of them. The tables. Actually, let's just stop for a second and talk about their tables for a moment. Yeah. Because they're busy.
Very.
Now, some of that's
to get the highlighter out.
Right. And some of that is just, it's the nature of the work they did, and they have a lot of data to represent. And I don't know that I could have done it any better, but it's still busy. And it took me a while to break down myself. And there's one table later on, which we'll talk about, which I'm very confused about. So I'm hoping that you can help me become enlightened. But anyway, in table 1, they say a few things about the population of women. A lot of this more is about who chooses to have a home birth than anything else, right? So basically, white women who are over the age of 35, who have higher education, and who are self-pay are more likely to have home births, which I don't think is news to anybody.
Correct.
So table 1, except for, just kind of saying that this population seems to be the population of home births that have been described before. So we can tell us that we're looking at the same population of women that we think we are. Other than that, it doesn't really tell us much information. The rest of table 1 looks at the second half of it, which is why it's so much to look at, is the neonatal deaths stratified by, all these different factors as well. And also by, who and where they delivered. There is some interesting things in here. I think that this kind of data here is a little self-explanatory and it's a little overlarge. So I'm actually going to, if you're okay with this, I'm going to skip on to the next tables, which I think are really where the meat of this study is. Mm-hmm. In fact, let's see. The second half of table 1, which is not their demographics, is they stratify all of these different factors by neonatal death, which again is part of the reason why this first table is so busy. But there are a few interesting things in here I think we can spend just a second on. And most of that comes down to the second part of it, which is on the second page, which is the newborn weight, gestational age, presentation, and this risk composite, which they're going to talk about a lot more later. Essentially, what I took away is, if you look at the breech especially, this is one of the things that really struck me, that there's only 118 neonatal deaths in the intended home birth, and 7 of them, which is a decent percentage, were in attempted breech deliveries at home. Now, I really want to know who is trying to do that.
Well, that actually goes back to, if you look at the first table, I would like to see the association between the no prenatal care or limited prenatal care folks and those that attempted to either deliver a breech fetus or perhaps a trial of labor at home. Are these folks that maybe avoided prenatal care in general? So that would be my guess, is there's probably going to be some association between the prenatal visit folks and the presentation and even the gestational age, newborn weight, if there was a diabetic association that we don't know about. So that's where I think a lot of this comes to the prenatal care, and what do they define as prenatal care? Because sometimes folks are getting their prenatal care the way they get their home birth, which is kind of in an informal setting. So that would be my guess.
I think that makes a lot of sense. They probably have those numbers. That would make a lot of sense to me, because I can't see. Well, again, we can talk about this in the discussion about the certification for home birth attendants. But I can, especially the ones I know, I can't see them being okay with trying to do a breech delivery at home. I mean, heck, I don't even want to do a breech delivery in a hospital.
Come on out to Texas.
Fair enough. Then to get into kind of the meat of the paper here, there's a couple stats. They're kind of buried in here, so I'm going to pull them out. When they looked at the overall neonatal deaths between the 3 groups, just to give these numbers out there, for the midwives it was 3 in 10,000 births. For the MDs it was 5 in 10,000, and then for the home births it was 12 in 10,000. And so, again, although the absolute numbers are not high, the percentage difference is high. It's over probably like 2.2%, 2.2 times increase over the doctor deliveries, 5 in 10,000 to 12 in 10,000. But the absolute numbers still aren't really that high, which is something I do want to keep in mind.
But that's also the argument you made, is where the standardized mortality ratio, or kind of a proxy for a relative risk, comes in. Mm-hmm. That even though in this current climate, overall numbers aren't high, if we were to say double the amount of women that attempt a home birth, or triple the amount of women that attempt a home birth, are we going to start seeing that mortality ratio hold? And then are we going to start seeing far higher absolute numbers of neonatal outcomes?
That is a very good point. I will cede that one to you. That is a very good point. You're right. And again, that comes down to, a few here and a few there, and you start talking about real numbers, is right. That, sure, it's only 12 and 10,000 now, but if only 100,000 women are having a home birth, say only, then you're looking at 120 neonatal deaths, with the preventable deaths being, some portion of those. But if now 5 million women are having home births, well then, starts to be big numbers. It's a good point.
Correct.
Then the next thing they look at is the individual risk factors. And again, I broke down some of their stuff into kind of easier to digest numbers for me, and some of these are in the paper as well. But one of the things that really struck me here is, again, I hate to go back to breech, but it is the highest risk for neonatal death, so I'm going to go back to it one more time. For doctor delivering in hospital, they had 1 neonatal or perinatal death for every 839 breech deliveries. For midwives, it was 1 in 640 deliveries, and for home births, it was 1 in 78. I mean, that
That
is
is frightening.
yeah. And some of the other numbers are, I mean, none of them are in that 1 in 78, but they're still kind of appalling. Even looking at the nulliparous, again, for the doctors, it was 1 in basically 1900. For the midwives, it was 1 in 2700. And for the nulliparous, it was 1 in 444, which is a huge increase in perinatal mortality from the doctors and the midwives. I mean, it's just nuts. And the same thing here holds true with the all the other risk factors, the TOLACs, the 41-week gestation, age, and even neonatal weight. Now, some of them aren't as drastic, but they're still very impressive. One of the things they're going to take, and the reason I wanted to say some of these numbers out loud, is they're going to take some of these numbers and they're going to argue for the inclusion of these extra risk factors in the ACOG criteria. And so what they're using is they're using the TOLAC numbers as kind of the reference point, right? And so the reference for the TOLAC was 1 in 529 home deliveries was complicated by a perinatal mortality. And so any of the other risk factors that came in at that number or under, they argued for inclusion.
Correct.
Right, which I thought was actually a pretty, I don't know if it's clever, but I thought it was a very simple way of determining whether something else should be added or not.
This is where the ethicist part comes in. Honestly, when I was reading that part, it's almost like a common sense application to a statistical problem in a way. And honestly, I could see clearly Larry McCullough arguing this point in a very kind of logical way, where if you use this as kind of if you looked at the risk factors from the committee opinion, trial of labor was one of the kind of messier between the British studies and the U.S. studies, some showing no difference, some showing drastic difference. So that was probably the one that was kind of at the trail end of being added as a contraindication. And honestly, I think a lot of it also was risk to maternal mortality, which this doesn't touch on at all. These are all, strictly neonatal outcomes. And so the trial of labor also really brings into play maternal outcomes. So if you're going to use that as kind of your contraindication and have that set of risk, then it only makes sense if you find more factors worse than that. Why wouldn't you include it as a contraindication?
Yeah, I really like I think you said it right. The simplicity of that was very appealing to my logical brain. And so just to run the numbers then, so like I said, TOLAC was 1 in 529 for home deliveries. The nulliparous was 1 in 444. The over 41 weeks gestation was 1 in 582. Age over 35 was 1 in 735. And then weight greater than 4,000 grams.
Yes, 4,000.
Was 1 in 1,019. So you can see from that, the three that are kind of closest together there are the nulliparous, the TOLAC, and the greater than 41 weeks, which, again, we're going to come back to in the discussion. Now, most of this data is found in Table 3, but Table 3 I found interesting, because especially if you compare Table 3 and Table 4, and this is where I want your help here, Dr. Ballas. So in Table 3, they have their 3 columns: risk for a midwife at a hospital, risk for a home, and then risk for physicians delivering in a hospital. And on the second half of it, they have what they call the standardized mortality ratio, but they don't really. I can't. Maybe you can help me figure it out. What are they referencing? What's the reference for each one of these? Because in the other, I think it is in the Table 2, they give us the hospital midwives as their reference, and they give us the SMR, 413 for the home birth and 166 for the hospital physician births. And so I get that, but then in that next table they break that style, and I have a hard time figuring out what those numbers mean.
Midwife hospital is always the reference point because they're in theory the lowest risk people.
Okay.
In general, midwife hospital births are the least complications because obviously as long as they stay low risk throughout the whole delivery. So that's why consistently you'll not only see physician deliveries be worse outcomes, but also with the planned home births being even more so.
All right, I get it now.
So basically, the argument that you can make from the last two columns, if somebody were to say, oh yeah, well, if I go to the hospital, the doctors are there and things are even worse. Basically, the worry of medicalizing their birth leads to worse outcomes. You can actually point this out and say, you're still at a worse risk trying to deliver at home.
Gotcha. Okay, no, that makes sense. I guess, without the visual, reference of the midwife hospital births,
right.
I didn't get it. So that's probably my fault.
Right. What I'm trying to tease out actually, so the first three columns, because I went straight to the last two columns because I could see verses. So the first three columns, they have risk in midwife hospital births, neonatal deaths per 10,000 births.
Right.
95% confidence interval.
Right. So that's just giving you, that's not the SMR, that's just giving you 2.6 per 10,000 births will have a neonatal death.
But where are you coming up with a confidence interval? I think that's what's throwing me off. Why isn't that just a...
That should be just a straight stat, right?
Why is that a risk? I'm trying to figure out how they... And looking in the results...
That is a good question.
They don't reference table 3 ever. Oh, here it is. Okay, hold on. I mean, they have these numbers that you were just talking about.
Yeah.
They reference table 3, but table 3 is not written like that at all.
But that's why I actually went through and recalculated the numbers myself, because I wanted to kind of put them all together in my head. And I found table 3 hard to follow.
Because I can understand SMRs with confidence intervals.
Yeah, I'm really not sure where they're getting the CIs from there. I think it's a mistake. I'm not sure. If one of our dear listeners can illuminate the subject for us, please write in feedback at obgyn.fm and let us all know why those are there, if you know the reason why.
Yes, I would be very curious to know what those confidence intervals are referring to.
Yeah. So anyway, let's move on to table 4.
Well, actually, one quick thing I wanted to bring up with table 3.
Oh, yes,
again, going back to our discussion of big numbers and big data and what that can do to make your results look interesting. The bigger the numbers you get, 13 million people. Look how tight these confidence intervals are.
Mm-hmm.
When you start seeing mortality ratios of 6 with a confidence interval of 4.3 to 7.83, nowhere near crossing 1.
Mm-hmm.
Very tight. I think it makes your data really pop out. And so I think that's another good point. But then when you do get down to the breach, like you'd mentioned, there's so few of them. The confidence interval for the planned is a mortality ratio of 8.14, but the confidence interval goes from 2.17 up to 14.11.
Yep.
So that's impressive.
Yeah, and, we had talked about this a little bit in the last Journal Club about subgroups. When you start really slicing your data down, and you get into lower numbers, and you can see the same even in this 13 million cohort of women they have. Even when they get down into these small numbers, they're getting these much larger confidence intervals. Now again, they have such a large number of women that they still manage to show significance. Right. But you can imagine if you only had 1,000 or even 2,000, you start slicing that down into small numbers, and you lose all your significance.
Right. But as a caveat to that, a little shout out to the physicians who are having lower mortality risk ratio with breech deliveries in the hospital compared to midwives. Just throwing that out there. Sorry.
So then at the table 4, what they do here is they say, okay, we're going to separate this into 2 groups. It's going to be any of the risk factors that we had talked about, so age greater than 35, nulliparous, post-term, previous cesarean delivery, or breech. versus women with none of those. So they're calling no risk, and they're comparing these. And I think what's interesting here is they're saying, okay, let's say we separated out all of the women who had these risk factors. Now let's look at these home births without that. So just like what you consider to be a low risk population. And even then, again, using the midwife hospital births as your reference, they still showed a dramatic increase in neonatal mortality for home births, even in the low risk population.
Right. And also with the physician population, interesting, physician to hospital births still showed an increase of 1.87
Right.
Mortality ratio, which I thought was interesting as well, but also speaks to, different type of patient.
Correct. That's exactly it. And they do mention that in their discussion that, I shouldn't say obviously, but anyone who works in a labor and delivery unit can pretty much tell you that obviously the patients that the doctors take care of as opposed to the midwives tend to be more complicated. Right. Hypertension, diabetes, all that kind of stuff.
Well, and also for risk factors, and this goes back to my, whenever the argument periodically flares up of midwife versus MD care, and you never want to make it an adversarial relationship, but the key phrase that always comes up is in a low risk population, midwife care is found to be superior for outcomes, which gets no argument from me. The caveat is, when does a pregnancy become higher risk? Mm-hmm. And that can go all the way to the point of pushing. And at any point in that relationship, you can become a high risk pregnancy.
Absolutely.
And so that's interesting to see that statistically, increased risk for physicians in hospitals, a standardized mortality ratio, because we have no data whatsoever about the intrapartum occurrences, which is another problem with birth certificate data mm-hmm. and these kind of post delivery databases.
Yeah, absolutely. And the other thing I think that from this table that's interesting is if you look at the no risk and then the at risk population, the actual increase in SMR for the physician deliveries was actually lower in the risk population. Mm-hmm. Which I found interesting. So actually the confidence intervals are actually they're all pretty tight still, but at least they're somewhat overlapping. Not actually, they don't overlap at all, but they're close. So you could basically call them the same.
And what that tells me, honestly, is that when a woman with risk factors is now being taken care of, well, then plans are made, preparations are in place, contingency plans, people are watched like a hawk. Mm-hmm. That doesn't necessarily occur in the intended home births.
Right.
And that's where you see any risk factors shoot up the mortality risk.
Right. Now, the last table before we get into the discussion is this table 5. And this is the one table I kind of wish they didn't put in the paper. I feel like I'm not really sure what they were going after here. Choosing 2 risk factors seems like weird. I mean, most studies like this would do some kind of regression.
Correct. And I think that's what this is kind of getting at. It's an interesting way of presenting the data.
Yeah, it's also very clinically relevant. I think that's what bothers me about it, is that women don't come with, factor A and factor B, right? They come with 1 or 2 or 4 or 5 risk factors. And so just having 2 risk factors, comparing them together, just seems very arbitrary and not like real life.
Well, I think it's some would look at this and say it's being kind of alarmist in a way of, setting off of the alarms right off the bat. If a nulliparous woman greater than 41 weeks says she wants to have a home birth, you have to look at that 40
right
mortality, risk neonatal deaths per 100 births pops out at you.
Right. I guess my point would be, what if they're nulliparous greater than 41 weeks and over the age of 35? Which is not a very uncommon scenario, but They don't give me the data on that.
They make you, I mean, honestly, some would just assume, well, then it's just
higher.
worse.
Right. Yeah, that's why I think I would have liked a regression so I knew which of these factors was most heavily weighting the outcome, right? Which is essentially what a regression does, right? Like which one of these things is contributing most to your outcome. That would have been, I think, more interesting to me from a clinician point of view.
I agree. I think that would have been um, an interesting addition, a different way to look at it.
Yeah,
Absolutely.
I'll have to ask Frank next time I see him why they chose to do it like this. I'm sure there's a reason. I mean, but it'll be interesting. If I find out, I'll let all you guys know.
Perfect.
So then, getting into their comment, they actually kind of rehash their argument like 2 or 3 different ways. And so I don't know how much time we want to spend on it. And we covered a little bit already. They basically say, they found these other risk factors that have the same poor outcome as the trial of labor, and so they feel like they should be added to the list of contraindications. And that's essentially their conclusion.
Correct.
Right. Their discussion on strengths and weaknesses. In strengths, they say it's a linked database between the moms and the babies, so that means that the data is validated. They also say that their limitation essentially is that you have to, as we talked about, you have to question the reliability of the data because it is a retrospective, birth certificate study. But as we talked about, with 13 million deliveries, any noise you have in that database is essentially going to be errored out. And they basically make that statement as well. Anything? I think that's basically all they say about strengths and weaknesses.
Correct. They also bring into the argument the other organizations that also have strict selection criteria, and these are countries that tend to have a higher percentage-wise of intended home births as well. And so, but they don't really go much into the detail of their mortality outcomes.
Right. I thought that was interesting. They mentioned that, and they don't really compare them.
Right.
But and then this is the part I think I really want to talk about with you, and I think it's maybe one of the reasons why you chose the paper. They have one paragraph in here talking about the American College of Nurse-Midwives. Right, and they state that they have no defined guidelines for patient selection for home births in the United States, saying that, quote, guidelines would impact midwives' autonomy and, quote, might not support midwives if they choose to attend the home birth of a woman with a breech presentation or twin gestation, or a woman who desires a trial of labor after previous cesarean. And I can't help but think that we, being the doctors, this is our fault. And I think you bring up the Dutch example they give, and even the English and Canadian, they have a much more collaborative process between midwives and doctors, and that has allowed them to work in tandem to say, we don't want to take your deliveries away, we want you to do them safely. So let's all get together and say what makes a safe delivery, whether it be in the hospital or at home, because at the end of the day, what we all want is for our women and their babies to be healthy, right? And we don't have that here in the United States.
No. One of the reasons I also chose this paper is, there in this country especially, from two sides of the spectrum is for us to start to demystify the home birth for physicians, especially classically trained physicians that go through the American system of medical school. The home birth increasingly has become this kind of mystical, foreign, scary situation that isn't really much respected. It's kind of thought of as very old world. And I can clearly remember the day in residency, one of our esteemed midwives gave me an education right off the bat when she overheard me talking about how I had counseled a woman against a home birth, basically saying women deliver in hospitals so that they don't die. And that was a quick education on my part. On the flip side, the argument can be made also is demystifying the hospital birth experience to women who do have an inclination to not want to medicalize their births. And I think part of that goes into really trying to change the conversation around natural deliveries.
Mm-hmm.
You know, the terminology of natural
Right.
and non-medicated and hospitalized and medicalized. And I think papers like this that try to really put statistics to an ethical argument as well as a societal argument can help in that, if it doesn't take itself too seriously in a way. That makes sense?
I think it does. I think, they instead of me speaking, I'm actually going to read again from their paper, and it's actually the last paragraph, and I think that I can definitely see Chervenek's writing here, his influence on this last paragraph. He wrote, "Home births in the United States have increased significantly over the last decade. Obstetricians and other concerned professionals should understand, identify, and correct the root causes of the recrudescence of planned home birth. Within hospital settings, they should create not only a strong culture of safety with the lowest possible risk, but also an environment committed to fewer interventions such as the prevention of first-time cesarean deliveries and to helping women experience a more home birth-like delivery." I think it's a very well crafted, sentiment saying that women have these concerns, and it's our job, if we're concerned about women delivering at home, if we don't want these basically bad candidates, what we consider bad candidates, to deliver at home, we need to figure out why they want to deliver at home and see what we can do to correct that so they can deliver in a way they're comfortable with, but with all the modern medical science behind them in case they need it.
And their providers as well. And that's what the midwives' argument was in their quote, I believe.
Right.
Was, we don't want to leave providers stranded if we make these guidelines, that there's going to be a point where patient autonomy trumps our guidelines, and you can't basically let someone hang out to dry who wants to provide care for this woman. We've created these guidelines that basically tie their hands, and you run the possibility of a woman basically trying to do this on their own. Worst case scenario.
That is a slippery slope.
Correct. So ultimately, what do you think? Should ACOG adopt these two additional risk factors?
I think they should. If ACOG can't get any of the other bodies, such as the College of Midwives, etc., to get together with them and come up with guidelines, then of course ACOG has to. I think they have a duty to put something out. I would much rather have ACOG take this data like this, and it's not the only study, but there are several here, and sit down with the American College of Midwives and come together and say maybe something a little less draconian. Like we do not recommend that women with these have home births because of blah blah blah, but we do understand patient autonomy, and we still want to be able to provide care for women who choose to do it. We just don't recommend it.
Correct. No, I think that a committee opinion by consensus, similar to how SMFM and ACOG had their peri-viability recommendations put out. It was a collaborative effort with a lot of neonatologists. I think it's definitely time for a collaborative opinion between nurse midwives, home birth attendants, MDs, and the pediatricians. I mean, you really you can't leave out the pediatricians who deal with the outcomes just like we do. I think they can offer a valuable information. And then ultimately, I think there should be a focus on increasing the availability of birthing centers or increasing the network of home delivery to hospital transitions.
Mm-hmm. And they do mention that the system, there needs to be a system in place to easily transfer these women to a hospital if they need to go there. And at my hospital, we had over not many, maybe one a year, maybe a couple of year, be transferred in from home, and we got better at it as the years went on. But the first few times it happened, it was like, who is this? Who is this patient? Who's taking
Right.
care of her? Is she a midwife patient, or is she a physician patient? And that confusion was not good.
They tended to be right, and they tended to be disasters, if I remember correctly. The higher proportion of them, it would be a labor that was taken to a degree we likely would not have in a hospital setting. So I think that also colors the perception of home births to a lot of MDs. And I'm absolutely guilty of that, since we usually are on the receiving end of deliveries that just were not going well.
Yeah, it's funny. When I have women, they come, my patients in the office, whatever subject it may be, whether it be IUDs or, inductions or whatnot, and they say, well, I was reading online or my friends told me, and this all happened to them. And I say, one thing to keep in mind, though, is that the only people who feel compelled to tell you about what happened to them are the people who had a bad experience. Right? The people who had an IUD and never had a problem with it aren't going to go around talking about it. Right?
Right. It's like the Yelp phenomenon.
What's the Yelp phenomenon?
Where the majority of complaints are going to be negative in nature.
Exactly right. And so in this sort of way, that's basically what you're saying is, the physicians in the hospitals, all we see are the ones that go awry. Like, we don't see all the home births that went absolutely fine. Right.
Right. And I guarantee you, within 10 minutes of any conversation with any physician about home births, the name Ricky Lake will come up. So we tend to, stick to our worst case scenarios.
Right. I thought this was a great paper to choose. I really liked thinking about this subject and about how we can approach it in a collaborative and collegial manner, but also from a position of data, right? And not to say that this data says that we should or should not do something. This data is saying, this is what happens. Now, can we all work together to make this, make more babies survive home birth? Or survive in general?
Or more babies survive home births because the correct segment of women are recommended to do so.
And then the last thing I wanted to just touch on here, because this is something that I touched on in my episode on fetal monitoring, is what is the number needed to treat, right? And so I talked in the beginning that there was one of the background papers that said that you had a significant reduction, a 6-fold reduction in operative delivery, but you had these increases in neonatal seizures and low APGARs. So you ask yourself, what, how many neonatal seizures or how many depressed babies is it worth to have X number fewer operative deliveries? And that is one of those things that it kind of like goes down to mammographies or even pap smears, right? How many false positives is it worth to not miss one cancer, right? And that is not, there is no answer to that question. There's no right answer.
Right. Exactly. I mean, that's where you really get into the murky waters of what is natural birth and what isn't. And I've had this conversation with patients that they really need to, take a step back from kind of our modern construct of obstetrical care and realize that in an age when women did deliver unattended or even attended at home, in various settings, the mortality for both mom and baby were extraordinarily higher than they are today. And we've managed to decrease that substantially. That does not make hospital birthing the number one 100% foolproof way of delivering. But there's something to be said about being able to bring such a high number down as dramatically as we have over the last century. Right. So there is something to be said for both settings, and there has to be more of a conversation rather than argument about it.
I mean, I really like his idea of how do we give women a home birth-like delivery in a hospital?
Correct.
And that, to me, I would say, it may be impossible, but that to me is like that is the goal. That's what we should be doing, right? We should be figuring out how do we give them the experience they want in a way that's safe as possible. Because I think what home birth is a surrogate for non-intervention birth. At least for most people, I think that's what it is. And so how can we give women that security that they're going to be in a place where no one's going to, be pressuring them to have their water broken or start Pitocin or whatever it may be, but that the, neonatal, doctors are there, the pediatricians are there, the obstetricians are there if, God forbid they need anything. So they have all these backup for them. They can still have the experience they want, but they have the safety net that we've developed over the last 100 years to prevent all the bad things that you were just talking about.
Correct.
That's the sweet spot to me. And that's what really got me thinking, and obviously, Jerry, that we work with a lot of midwives in my hospital. And so I've talked to them a lot over the last, few years, but even the last few months since the podcast started, about these sort of topics. And so it's really, really piqued my interest. And I've been thinking of ways, and from an institutional point of view, how do we craft that?
I mean, one solution, when I was in fellowship at UC San Diego, the floor above our traditional labor and delivery was a birthing center. Now, on the outside of the rooms, there's only so much you can do within the confines of a traditional hospital. But when you did go into the rooms, it was a completely different feel. They did a very good job, as best they could, with the furniture, with the lighting, with the way the room was set up, the minimization of the medical instruments. So it did look like you were walking into essentially, if not an authentic living room, at least a close approximation of one. But you were right upstairs from labor and delivery, and I can speak from experience. Occasionally we were up there doing an operative delivery or bringing a woman down for cesarean delivery, but that was very few and far between.
Well, you probably had a very I'm imagining, good criteria for who belonged in that unit and who didn't belong in that unit.
Absolutely.
Right.
Correct.
So, anyway, so this was a great topic. I think it provoked a lot of thought in Jerry and I hope that all of you, were provoked to think as well. Seems like we're going to make a monthly thing out of this, Jerry, huh?
It's looking like it.
All right, so we're going to keep doing this month after month. Like I said last time, if you guys have articles that you are interested in, that you want to see us discuss, please send them in. Again, this article is linked in the show notes, so you can get to it and read it. Thank you all for listening, and I look forward to being with you all again soon.
Thank you all.